So these are the 5 different classes of antihypertensives: calcium channel blockers, RAS inhibitors, diuretics. These are the first line drugs. In this also, in RAS inhibitors, these are the first line drugs: ACE inhibitors and angiotensin receptor blocker, not renin inhibitors. Okay. Then we have sympatholytics and vasodilators. In sympatholytics, we have beta blocker, alpha plus beta blocker, and central sympatholytics. Okay, so many drugs. Now, when to use which one? Okay, so that depends, one, on the side effect profile of the drug. Okay, so we should know their side effects. Why? Because in some patients, these side effects may become too much. That is one thing. Second, in patients with comorbidities, okay, like suppose if a patient is suffering from diabetes mellitus, maybe there are certain drugs which can be harmful in that diabetes mellitus. Okay, so we have to decide on the drug based on the patient profile, if is he having any comorbidities and the side effects of these drugs. Okay, so let us go into that what are the various indications of these drugs. Very simple, we will try to discuss. Okay, what are the various indications of each of the classes of these drugs, right? Now, first is calcium channel blockers. Okay, so calcium channel blockers, I said there are 2 types are there. What are these types? Non-DHP and DHP. So which one is preferred? First preferred, if there are no comorbidities, is non-DHPs, and it is the first line drug also, right? So when the patient comes, first line drug, if the patient is not having any comorbidity, then it is calcium channel blocker. Okay, and that too long acting DHPs. Okay, and among this amlodipine, because amlodipine is long acting, once a day dosing is enough. Okay, that is CCBs. These CCBs are also preferred in patients with peripheral vascular diseases. That means if the patient is having some disease in which the blood supply to the organs is limited. Peripheral vascular diseases, already the blood vessel is constricted. So CCBs, we have seen, they act by dilating the blood vessels. Okay, so they are preferred in patients with peripheral vascular diseases. If the patient has renal artery stenosis, okay, they are also preferred in elderly. Then isolated systolic hypertension. Because they have been found to be more effective in isolated systolic hypertension. Okay. Next, we have ACE inhibitors and ARBs. When are these preferred? ACE inhibitors, ARB, if the patient is having hypertension with diabetes mellitus, okay, with diabetic nephropathy or any other nephropathy, except they should not be renal artery stenosis. In renal artery stenosis, these RAS inhibitors are contraindicated. Okay, because if they are given, then the blood flow to the kidneys is totally compromised. This I have already discussed in the video on RAS inhibitors that you can watch in detail. I have discussed everything. Okay, so they are not used in patients with renal artery stenosis, but any other kind of nephropathy they are used. Then another diabetes mellitus complication is retinopathy. So hypertension with retinopathy, they are again preferred. Okay. Then post MI, they are preferred, post myocardial infarction. Okay. Then patients hypertension which is complicated by stroke. Okay. That also ACE inhibitors are preferred. And hypertension with metabolic syndrome. Okay, because it doesn't has that any side effects in this relationship. We'll see another drug which are having that side effects. Okay, so these are the indications for giving ACE inhibitors or angiotensin receptor blockers. CCBs, first line drug. If any problem giving CCBs, then we go with ACE inhibitors, especially if the patient has these comorbidities. Then the first choice of drug is ACE inhibitors. Secondly, in younger patients, sometimes it is preferred. Younger patients, less than 55 years of age. Okay, sometimes it is preferred because in them, activity of this angiotensin 2 is found to be higher. But nowadays, they recommend that all ages, first line of drug is calcium channel blockers. All ages. First line of drug is calcium channel blockers. If the patient is not able to tolerate these calcium channel blockers, then we are giving ACE inhibitors. Or if the blood pressure is not being controlled with calcium channel blockers, then a combination therapy has to be started. See, not being controlled means we have already seen what is the target blood pressure. Target blood pressure is less than 130 by 80 millimeter mercury with drugs. So, if the blood pressure is not being controlled, then we can combine them with the other drug. Okay, so that will help control the blood pressure, and generally it has been seen that combination therapy only is required to achieve the target blood pressure. Okay, so that is CCB, ACE inhibitors. Moving on to diuretics. When will we need diuretics? So diuretics, we saw that there are three classes: thiazide diuretics, loop diuretics, and aldosterone antagonists. So first choice of drugs for the treatment in hypertension is thiazide diuretics. Thiazide diuretics. Okay. We will not prefer loop diuretics and aldosterone antagonists except when there are compelling indications. That means specific indications for these, then only we are going to give these drugs. Now remember, these thiazide diuretics again helpful in isolated systolic hypertension, helpful in elderly. Okay. Then remember one thing, the thiazide diuretics are moderate antihypertensive. That means when we give these drugs, generally they reduce blood pressure by approximately 10 millimeter mercury. Okay, so if there is a severe hypertension, then can we give thiazide diuretics? No, we cannot give only as a single drug. Okay, if it has to be given, it has to be combined with other drugs because it doesn't reduce by itself too much blood pressure, approximately 10 millimeter mercury only. However, when it is combined with other drugs, then it acts synergistically. How? See, when you are giving these drugs, CCBs, ACE inhibitors, yes, there is fall in blood pressure, but body starts the compensatory mechanisms, and these compensatory mechanisms, they basically increase the blood volume. Understanding, body is adjusted to that kind of blood pressure, so you are trying to decrease that blood pressure, so body will think, oh, my blood pressure is falling, it will start the compensatory mechanisms, right? And that is going to increase water reabsorption from the kidneys, increase in the plasma volume. So when you give this thiazide diuretics in combination with other drugs, what is going to happen? This diuresis will occur, so plasma volume expansion is not going to occur. So that way, in combination therapy, these thiazide diuretics are very good, even though they are mild to moderate hypertensive, but should not be given alone if it is severe hypertension. Fine. So remember, they should not be given in severe hypertension. Then they should also not be given in gout, because these thiazide diuretics leads to hyperuricemia, increase in the uric acid levels in blood. So they should not be given in gout. But they can be given in case of osteoporosis. So again a comorbidity. Okay. If osteoporosis is present, then thiazide diuretics, what happens that they prevent the calcium loss from the kidneys. So they are maintaining the calcium levels in the blood, so they will be helpful. Understood? So that is thiazide diuretics. Loop diuretics. Loop diuretics are actually not the preferred drugs for hypertension except in case of severe hypertension. Okay? Severe hypertension they can be used, because I said thiazide diuretics are not used in severe hypertension. They are used if hypertension is complicated with renal failure. Right? So these are the two main uses of loop diuretics. Then we have aldosterone receptor antagonist. Okay. So what it is going to do? It is going to decrease the action of this aldosterone. Aldosterone is not going to act, and that is going to decrease the reabsorption of the sodium ions and hence decrease water reabsorption. But this aldosterone receptor antagonists are mainly the drugs which are used in case of resistant and refractory hypertension. Especially whenever the word refractory comes, if the patient is not responding to any antihypertensive drug or to the combination therapy. See, we have said these are the main agents. Now suppose you added CCB, patient did not respond, you are not achieving the target goal. You add the ACE inhibitor, still not achieving the target goal. You add the thiazide diuretic. Okay. Still not achieving the target goal. What to do? We have to add this aldosterone receptor antagonist, because it is thought that the patient is not responding because the aldosterone levels have increased so much that the patient is not responding to other drugs. So even you are blocking ACE inhibitors, ARB, aldosterone is increasing maybe due to some other causes. So we have to directly block this aldosterone receptor. So that is for refractory hypertension, right? But remember that aldosterone receptor antagonists, they cause hyperkalemia. They increase the potassium levels. And if you give them with ACE inhibitors or ARB, if you give it with that, then what will happen? They are also causing increase in the potassium retention. Potassium is not being lost from the kidney. So if you are combining these two, then potassium levels can increase dangerously. So it is very important to monitor for hyperkalemia. Okay, when I talked about ACE inhibitors and ARB, just one thing you remember here, that the side effect of ACE inhibitors is cough and angioedema. So if these drugs are not tolerated by the patient, then we switch to angiotensin receptor blockers. Okay, both of these cannot be given if there is renal artery stenosis. But you start with ACE inhibitor and the patient has side effects which is not able to tolerate. Obviously, angioedema means immediately ACE inhibitor has to be stopped. Cough also, it is very bad, dry cough is there, person is not able to tolerate, we have to switch to ARBs. On the other hand, renin inhibitors, aliskiren is there, that is hardly used. Okay, if the person is not responding to any drug, then maybe it can be used, but generally it is not used. Fine. So we discussed about diuretics. Moving on to sympatholytics. Sympatholytics. So what are these sympatholytics? We have seen that there are beta blockers, there are alpha blockers, there are alpha plus beta blockers. Okay, so how to use them? So first is the beta blocker. Okay, beta blocker, before they were the first line drugs, now they are not the first line drugs, but there are certain indications for beta blockers. What are these indications? If hypertension is present in case of stable angina. Okay, stable angina, beta blocker is the prophylactic drug. Okay, that again I have discussed in the video on anti-anginal drugs. You watch that video. Stable angina, beta blocker is used for prophylaxis. So in hypertension with stable angina, we give beta blocker. Then hypertension with chronic heart failure, we give beta blockers. Okay, so again in these both of them, it decreases the oxygen demand, so they can be given, right? They are also given in hypertension with HOCM, hypertension with migraine, okay, and hypertension with aortic dissection. Why? See, beta blockers, how they are going to act? They are basically going to decrease the heart activity. Okay, so they are blocking the action of norepinephrine on the heart and also on the kidneys. So kidneys, yes, they are decreasing the RAS, okay, because renin release is less. But because of its action on the heart, there is decrease in the oxygen demand. So stable angina and heart failure, they are used. HOCM, again, HOCM benefits when we decrease the contractility. So HOCM is what? Hypertrophic obstructive cardiomyopathy. In this, there is obstruction at the aortic level. Okay, so when there is increased contraction, that obstruction increases. Okay, so that's why beta blockers help in HOCM. Migraine, Actually, beta blockers are used for prophylaxis of migraine. Okay, so that also helps. And aortic dissection. Aortic dissection, what happens that you decrease the contractility of the heart. When contractility increases, then the pressure is decreases, and this helps in aortic dissection, because otherwise if heart is contracting too much, then the pressure will increase the aortic dissection. Okay. Then what are the side effects profile of beta blockers? Basically, when can they not be given? Contraindications, they are avoided in asthma, in fact contraindicated. Okay, diabetes mellitus, peripheral vascular diseases. Please see my video on beta blockers for details on all of this. Okay, so that is beta blockers not to be given. Then moving on to alpha blockers. Alpha blockers, when are they preferred? Not the first line drugs. We have seen first line drugs are CCB, RAS, diuretics, not responding to what? Give combination therapy. Alpha blockers, but given when hypertension is present with benign prostatic hypertrophy. Okay, so these alpha receptors, they are present in the vessels we have seen, but they are also present in the urinary bladder. Okay, so this is the urinary bladder. Here, alpha receptors are present. So when you give alpha blockers, there will be relaxation of the urethral sphincter. Okay, so because of the relaxation of the urethral sphincter, they improve the passage of the urine in BPH. Prostatic hypertrophy, what is the problem? There is blockage of this pathway because of the prostatic hypertrophy. So relaxation of the urethral sphincter promotes the passage of the urine. Okay, so that's why in hypertension with BPH, alpha blockers are present. Alpha blockers are also preferred in case of hypertension due to increased adrenergic activity. Okay, that is known as hyperadrenalism, increased adrenergic activity, and that occurs in conditions like pheochromocytoma. So in pheochromocytoma, actually first alpha blockers are given and then we add beta blockers. Okay, so that is pheochromocytoma. Cheese reaction. Cheese reaction occurs because of the interaction of certain drugs with old cheese. That's why the name cheese reaction. Okay, so that is cheese reaction. It can lead to extreme rise in blood pressure, and then there is also clonidine withdrawal hypertension. Actually, this clonidine is a central sympatholytic. So it was seen that okay, when clonidine is given for little long duration and when it is stopped suddenly, then there is clonidine withdrawal hypertension. Why it occurs? Why it occurs? Because what happens that when decrease of the release of norepinephrine is there, the central sympatholytics, what they are doing? They are decreasing the release of the neurotransmitters. So when this neurotransmitter decreases, the release is less, then there is increase in the receptors on the membranes. This is fundamental physiology. Okay, so here this is presynaptic membrane, postsynaptic membrane. When the neurotransmitter release decreases, body doesn't know why it is happening. It tries compensatory mechanisms. Okay, so that okay, action should occur. So there is increase in the receptors here on the postsynaptic membrane. Okay, now you have been using clonidine. Chronically there was decrease in the norepinephrine, and now because of that there is increase in the neurotransmitters. Now you remove the clonidine. Now what will happen? Norepinephrine secretion will resume. It is going to act on so many receptors, and hence there will be clonidine withdrawal hypertension, because now the effect of the norepinephrine will increase. So in that case also we use alpha blockers. Understanding? So in case of hyperadrenergism, we use alpha blockers. Okay. Then central sympatholytics, we have clonidine. Two drugs are there, clonidine and alpha methyl dopa. Clonidine and alpha methyl dopa. Now these are not commonly used except alpha methyl dopa. Alpha methyl dopa is used in case of pregnancy. It is a safe drug in pregnancy. In fact, these ACE inhibitors are contraindicated in pregnancy. Should never be given because they act on the kidney development in fetus and cause renal agenesis. They are fetopathic drugs. ACE inhibitors and ARB should not be given. Even renin inhibitors, all the drugs which act on RAS inhibitors, they should not be given because they are fetopathic. They should not be given in pregnancy. In pregnancy, safe drug here is alpha methyl dopa. Another safe drug is alpha and beta blocker, that is labetalol. Labetalol, safe drug in pregnancy. Okay, so this alpha beta blocker, labetalol, and central sympatholytic alpha methyl dopa are used in pregnancy. Fine. Then moving on to the last part, that is the vasodilators, that is arteriole and arteriole venodilator. Arteriole dilator we have hydralazine, and arteriole venodilator we have nitroprusside. Now these drugs, hydralazine, again can be given in pregnancy. Okay, so suppose we have given labetalol, patient is not responding. Alpha methyl dopa, patient is not responding. We add hydralazine. Arteriole plus venodilator, that is the nitroprusside, that is given in hypertensive urgencies. Now not the first line drug, but it is used there. So these drugs which are not used routinely, that is the alpha methyl dopa, labetalol, hydralazine, and this nitroprusside which I told is used in hypertensive urgency, not the first line drug, that we are going to deal in the next video, where we talk about the special conditions, that is in case of pregnancy, hypertensive urgency and hypertensive emergencies. Okay, so that was about antihypertensive. We discussed about main 4 classes of drugs we discussed. I think we have not discussed about non-DHP CCBs. Non-DHP CCBs, as I told, it acts on the heart as well as on the blood vessels. So when can it be used? See, non-DHP CCB is also decreasing the contractility. So in case beta blockers indication is there, understanding like stable angina, heart failure, all these beta blocker indication is there, but contraindication is also there. That means the person is asthmatic. Then in that case, we will go with non-DHP's calcium channel blocker. So instead of beta blocker, we can give non-DHP calcium channel blocker. Fine. So that was the various classes of antihypertensive. We saw 5 important classes. We saw their mechanism of action, fundamentals combined with physiology. We saw when they are specifically indicated. Thanks for watching the video. If you liked it, do press the like button, share the video with others, and do subscribe to the channel Physiology Open. Thank you.